Good afternoon, all. Welcome back. Today we are going to have our 12th session of Foundation Course in Palliative Nursing. We are going to discuss on gastrointestinal symptoms too. That's a continuation of the last class. We have Dr. Arjun Devaraj as our faculty here and Shiva ma'am as our facilitator. Shiva ma'am will be giving a brief introduction to our faculty and today's topic. Shiva ma'am, please.
Thank you. Hearty good afternoon to all. As senior said, today we are going to learn about the second part of gastrointestinal symptoms. So that is on intestinal obstruction. So this will be taken by Dr. Arjun, who is a palliative care physician having multiple years of experience in palliative care. Currently, he's that session head of the medical service here. He is working here. So welcome, Dr. Arjun, and over to you.
Thank you, Sir Shiva. Good evening, all. So we shall start with the management of PA symptoms part 2. So we will start with the case history. So a 50-year-old female who was suffering from carcinoma of pancreas, who presents to you with sudden worsening of abdominal pain, constipation since a week, severe vomiting which renders her unable to take anything orally, not even sips of fluid. On examination, her vitals are normal, but her abdomen looks distended and is very tender. You asked her and you couldn't hear any bowel sounds. And you sent for an X-ray and you got an X-ray back. So this is the X-ray you got, X-ray abdomen, right? So have you ever came across such a situation? Okay. So what do you think it is? Anyone, any suggestions? So why do you think it's an intestinal obstruction?
Shikha?
Kanpara, you think it's intestinal obstruction. So what help you with the diagnosis? So what do you do?
Shikha, please unmute your and then talk. Why you are thinking this is intestinal obstruction?
Because of the air kind of in this special.
Your voice is not clear.
Ma'am, in X-ray, the intestine are visible like kind of air is present. Yes, sir.
So, okay, from the history, so you can expect such cases presenting to you very often, especially with carcinomas that are affecting your intestine area. More commonly, say ovary and other say pancreas and all of it. In most of the conditions, you can expect intestinal obstruction. So it is one of the rare complications of the cancers. It is a palliative care emergency and has to be managed well. Because you see the million of symptoms that the patient has presented with, all these are very worsening their suffering. So there's severe pain, constipation, vomiting, even not even unable to take 6 of fluid, distended abdomen, and all these things. So in this X-ray, you could see the point. So multiple molecules are fluid, air fluid level. So you can see this here. There's an air level, and there is also fluid level. So these are indicative of intestinal obstruction. So X-ray is very helpful in such conditions, and it's also very cheap and less invasive. So X-ray can be used for diagnosis in intestinal obstruction. So for the ease of clinical management, so we can classify bowel obstruction as to 4 levels. The first one, the esophageal level. Esophageal level, where the most common site of obstruction would be gastroesophageal junction. So you see the gastroesophageal junction, then the gastric outlet and proximal small bowel. Then there is a distal small bowel and the large intestine. So these are the most 4 levels that we classify in bowel obstruction. So how bowel obstruction takes place? It could be either mechanical or functional. Mechanical, so the mass, a tumor mass or something mechanical could be obstructing the gastric intestinal lumen, causing the obstruction. Or it could be functional, where the peristalsis, the peristaltic movement of the intestinal lumen could be failed. So the peristalsis is not properly working. So that's a functional obstruction. See, this obstruction could be partial or also called as incomplete. So there, the lumen is partially closed, not fully closed. So we can see in such patients, we could see that the patient would be passing flatus. Even though there is constipated, flatus would be passing. And on examination, we could find that bowel sounds will be very hyperactive. And colicky pain is an usual presentation. So when it comes to complete, there is no flatus in the last 72 hours. It could be either hyperactive bowel sounds or there is no bowel sounds at all. The colicky pain may also be present with complete obstruction. So there is importance between identifying whether it's complete or non-complete. Then there is acute and chronic. You can classify as acute and chronic based on the duration. And usually long-term history of constipation and lower abdominal cramps, those are usually indicative of a fecal infection also. There the fecal material is got impacted and causing the intestinal obstruction. So this is like a pathophysiology of intestinal obstruction. So what happens is, so you can see that the obstruction, so something is obstructing the intestinal lumen here. So what happens? Nothing passes past. So the stool or the food, what we have taken, that is not passed. So it causes an obstruction. And it becomes dilated because there nothing can pass beyond this obstruction. So what happens next? There is accumulation of intestinal contents. Okay, here, the accumulation of intestinal contents and also the solid air gets accumulated here. So proximal to the intestinal obstruction, there is severe contraction. So the bowel is intestine is trying to push the collected food or gas to beyond the obstruction. So what happens is contraction increases. This increased contraction will cause the colicky abdominal pain and will also causes the emesis. So it is trying to push forward, it gets obstructed and it comes back. So the patient vomits. Okay. Then, so what happens is it's trying to push it forward and it's not going forward and it causes dilation. So the intraluminal pressure increases and abdominal distension takes place. So you know that there is bacteria within the food and it's also continuing its functioning. The food is getting accumulated there. So there will be severe gas. Gas is also produced. That will add on to the dilatation. Once the dilation goes beyond a point, the veins and arteries of the wall get obstructed, and there will be also edema of the abdominal wall. Sorry, bowel wall. By the time the bacteria has grown, made colonization has happened, and it will start necrosing the abdominal intestinal lumen. So that will lead to full ischemia has happened, and necrosis also starts place, which will end up in perforation. Perforation. Once the perforation is a very severe painful condition, and what happens is it will lead to peritonitis, and the patient may go for shock, and he end up dying. So this is a pathophysiology. So there's an obstruction happening. There's accumulation, the intestinal lumen dilatation. There's edema and necrosis starts happening, perforation, peritonitis, and shock, and the patient ends up dead. So this is why intestinal obstruction is considered as a palliative care emergency. So what causes these intestinal obstruction? Most often what we see is a cancers. So cancer, it may cause both mechanical and functional obstruction. How mechanical? Because a cancer growth, it could either metastasize or the tumor itself can obstruct the lumen and cause an intestinal obstruction. At the same time, it may affect the nervous system and cause functional peristalsis also. So peristaltic failure. Then there's history of past treatment for the cancer or any other conditions, which has led to intestinal adhesions, post-radiation ischemic fibrosis, where in the following abdominal radiation, even drugs like opioids and antimuscarinic drugs will cause intestinal obstruction. Debility, the fecal interaction, electrolyte imbalance, some electrolytes which may affect the peristaltic movement can also cause intestinal obstruction. And most common non-cancer cause of intestinal obstruction is strangulated hernia. So the clinical features. So we can get a vague idea of what level of obstruction from the clinical features. So in esophageal obstruction, that's a first level. Usually the patient will present with dysphagia to solids. So the patient will be complaining he can't take a solid food initially. Later he may come back saying that he is having difficulty taking even liquids. So that is an indicative for in esophageal level for a gastroesophageal junction obstruction. When it comes to gastric and small intestine obstruction, there will be severe vomiting even with small quantity of oral intake. Even with sips of fluid, the patient will start vomiting. There is severe retrosternal and epigastric discomfort, gastric distension. So these may be indicating of a second level obstruction. In case of distal obstruction, vomiting is less frequent. It will be there, but less frequent. Foul smelling and fecal. So sometimes you can see that the vomitus will be fecal matter. It will be dark color and foul smelling as of a fecal matter because it's a distal obstruction. The most devastating clinical feature would be an abdominal pain, which is usually colicky pain. Then there is constipation and diarrhea. Why have I mentioned diarrhea? So what kind of diarrhea can you expect in such a patient? I think I went through the session. The patient had a constipation and he later comes out with diarrhea. Or does that diarrhea indicate that its constipation, sorry, its obstruction is done with? So where does that fluid come from? Remaining fluid? I don't know what you meant. Okay. Any other answers? So, what do you call a patient with diarrhea presenting after constipation? So, what should we look for?
Please answer this question. So after a period of constipation, if the patient is complaining of diarrhea, what is the diagnosis? How will you evaluate?
Maybe fluid leakage or some contents of intestine will come after constipation.
Any other answer? Any specific name for that? Yes.
Inflammatory bowel syndrome.
No. Okay, so have you heard about the term spurious diarrhea or secondary diarrhea? So,
Sir,
yes.
sir, can you repeat the question?
So, okay, we'll go forward. So, it's called as spurious diarrhea. So, the patient, what happens is when patient is becomes constipated, the fecal impaction can cause obstruction, and the fecal material gets. So, as you go back one slide. So, what happens here? So, I can show you this. So, the fecal matter gets obstructed, and the body is continuing food production. The food is continuing here. There is dilation. There is see the constipation. The food is being fermented. Gas is developing, and there is even dilation. So what happens is some of this fluid and this gas can escape through the side of the impaction, and it will come as a watery diarrhea, very foul smelling. So that's called a secondary diarrhea. So secondary diarrhea or spurious fluid. So whenever a patient comes with history of diarrhea, you better ask for a history of constipation preceding that. So then actually the patient won't be having a diarrhea. It will be after effect of a constipation, which you may have to leave with a hyperemia or anaphylaxis. Just because a patient says diarrhea, we don't have to go for a manage it as a diarrhea with like anti-diarrheal medications. Okay, and actually the patient will be having a constipation. So that has to be rolled out always when the patient comes with diarrhea. I hope I made you clear. So we shall continue. Okay, so on examination, the bowel sounds may be either absent or hyperactive. Usually it's absent in a functional where the entire lumen is obstructed by the cancer, or it could be hyperactive in a mechanical. See, investigations, so we know that electrolyte imbalances can lead to intestinal obstruction. So hypercalcemia and hypokalemia are most common common causes of constipation. So we may have to correct these situations. Abdominal X-ray is very cheap, less invasive, and easy to get investigation to confirm for a intestinal obstruction. CT is obviously the gold standard investigation. So the management of an intestinal obstruction is usually surgery. So can we opt for surgery for everyone? So when can we go for surgery? So you may be seeing patients at various levels. So various health conditions, various reasons for constipation, intestinal obstruction, and who all can be given for surgery. So some of the indications are: he's having a good general condition. The patient should be much healthy. Single discrete organic obstruction, a single lesion that is causing the obstruction. There is no disseminated disease, no much of mental lesions or intra-abdominal peritoneal lesions or something. The patient could be very independent and active. He is not much dependent on others. Has a weight loss of less than 9 kg since the disease. And the most important thing, the patient who is willing to undergo surgery. As you may know, the patient autonomy is the first thing that you have to consider. If the patient is not willing for surgery, that is not it should never be sent for surgery. So likewise, when we cannot go for surgery, there's diffuse intra-abdominal tumors. The tumors are spread throughout the abdomen, multiple palpable masses. History of obstruction. The patient could have a re-obstruction. Already had an obstruction which was cleared early, and a re-obstruction takes place. History of previous laparotomy, there are severe adhesions, previous abdominal radiation, poor general concentration, very poor nutrition, and large ascites. These are some of the contraindications for a surgical candidate. So this acts like a triad. Like you see, increasing gastrointestinal distension. So it also increase secretion and reduce reabsorption, reduce motility. All these factors, these three factors complement each other and will add on to the patient suffering. So GI distension increases. By the time the same will cause increase in secretion and reduce reabsorption. This is the same thing will cause GI distension. GI distension increases, motility is also reduced. Motility reduced, GI distension occurs. So it's complementing each other, which will add on to the patient suffering. So what we want to is to manage these three main issues to reduce suffering of the patient. So how do you manage an incomplete malignant bowel obstruction? Incomplete bowel obstruction, let me repeat, the entire lumen is not fully obstructed, only partly obstructed. Something may at least the gas will be escaping through that. So there we can manage steroids, corticosteroids. So what happens is the corticosteroid can reduce the periluminal edema. So when there is a tumor, there will be a region of edema around the mass. So it's called a peritumor edema. So dexamethasone is an anti-inflammatory drug. So it will reduce the inflammation. So it will reduce the size of the tumor for some time, at least for some time, to some extent, so that the obstruction gets relieved. Then we need an antacid. So there will be increased secretion and reduced reabsorption. So there is severe gastric juices will be there. And we need a proton pump inhibitor or a ranitidine. So we usually prefer ranitidine because it will reduce the intestinal secretions. It will help in reabsorption. So rather than you putting a patient with pantoprazole, we would prefer to put the patient on ranitidine. Then we can go for a combination with hyoscine butyrate or with the parenteral haloperidol, with or without an opioid. Continuous subcutaneous infusion would be the ideal route of administration in case of incomplete bowel obstruction. And one more thing you have to start is an antiemetic. Which one? If there is no polyp, start a prokinetics and monitor for the response. The prokinetic drugs, they will increase the bowel motility, and that will help you overcome that obstruction in case of a incomplete bowel obstruction. But one thing you have to monitor is these prokinetics may cause colicky pain. So if a patient has incomplete bowel obstruction and the patient has a colicky abdominal pain, do not go for a prokinetic. Go for other option like a conservative management for complete bowel obstruction. Do not start a prokinetic. If the patient doesn't have a pain, colicky pain, go for prokinetics. Okay, I will explain the prokinetics and drugs later. Okay, so which is a prokinetic, you know? Can you mention some? So which is the one available at your center, at least, that you may come to know whether you can't get to use every day?
Domperidone.
Yes, domperidone is one. Any others?
Metoclopramide.
Yes, thank you. Metoclopramide. Good issue. I'm sorry to know there's an audio issue. Is everyone able to listen? Is anyone else having an audio issue? Are you able to listen to me?
Can you able to hear clearly? Is there any that
Are you able to hear
audio?
me? Yes. Okay.
Yes,
Yes.
fine.
Okay.
Thank you.
Yeah.
Thank
Okay.
you.
Yeah.
Kindly check locally. Okay, so prokinetics, you start with metoclopramide and domperidone are drugs of choice. So how do you manage an inoperable bowel obstruction? So the patient comes to the category where you cannot suggest a surgery or the patient cannot tolerate surgery. Always try to resolve the reversible components of the distress and symptoms. Not the disease, but the reversible components of distress, which you can manage yourself. Like the background pain, the colicky pain, nausea, vomiting, distension. Those could be managed in case of inoperable bowel obstruction. The bowel wall swelling and reversible components of obstruction can be managed with corticosteroids, which I already mentioned. Treat the pain, the nausea, vomiting, reduce the luminal secretions. Same thing that we mentioned in this last cycle. So we have to reduce the GI distension, manage the motility problem, reduce the secretion, and increase reabsorption. So to manage the pain, morphine is usually substitute used. It's a drug of choice and will help with the pain. Make sure the patient has round the clock availability of morphine and enough for PRN doses also. In case of a severe breakthrough pain episode, the patient should be availed morphine. In case of a colicky pain, you may have to go for an Arjun, like an antispasmodic, antisecretic, or antiemetic. And the best choice of route of administration would be continuous subcutaneous infusion. So a patient is having, so you have a patient with intestinal obstruction, with poor general condition, poor performance status, very advanced peritoneal disease, history of abdominal radiotherapy, very cachectic, bedridden, and you have suspected prognosis very less than like 12 weeks. Or at the same time, the patient and the family makes an informed decision on minimal invasive conservative treatment. Like make sure that's an informed decision. So the patient and the family should be aware of what happens if they opt for no surgery and what all they can expect in the future and how we can help them manage it. Only if, so that's something that I said earlier. So when the patient says he doesn't want to go for surgery, we'll have to inform them fully and make them aware that what is going to happen. So if such a patient comes, what all can we do? Nasogastric tube can be used for decompression. I want to ask one thing. Can nasogastric tube be regularly used for a patient with intestinal obstruction? Just forget the slide. So can we regularly use? That's a question. In case of every patient who comes with intestinal obstruction, will you go for nasogastric tube? Yes, to decrease blood pressure. Okay, then how long will you use that? Not always. Okay, Mahima madam. So when will you use? Eight to 5 days. So we don't use nasogastric tube regularly. It can be used for a short period of time, only to relieve the intestinal distress, to decompress. So when there is increased secretion and it cannot be on the point there is intestinal abdominal distension, that will, if that is going to be a issue with the patient, we can go for a short period of time and go for decompression. Okay, then use an antiemetic without prokinetic action. Continuous subcutaneous infusion with antimuscarinics with or without opioids for the pain. PPA proton pump inhibitors or ranitidine isobutane injection as additional antisecretory. Make sure you have maintaining hydration because the patient won't be able to take food normally. Adequate pain relief has to be assured. Sips of clear fluid or licking favorite fluid. The patient would, there is nothing much point in giving a nil per hour. See, nil per hour may work in some kind of mechanical obstruction, but that too was an initial phase. By the time it gets recur, there is no point in giving a complete bowel rusting for them. So the patient, you can give some sips of clear fluids, and patient would like to take some favorite food. So you can ask them to take a little licking, at least very small amount for their well-being. So what happens when the patient is moribund in the terminal stage? We can use nasogastric tube to give the stomach compress for some time. Subcutaneous route saline to hydrate as a shared decision with the family. So the family will be very much concerned. That's something we often see, that the patient is not taking anything. So how can we start them to? So we can try to convince them that food is not the concern right now. And for their benefit, we can go for subcutaneous route hydration. Any of your centers use subcutaneous infusion fluids? Okay, so you will have a session on subcutaneous infusions. So what we use is normal saline. We can give it as a subcutaneous fluid, like 1 pint over a period of 24 hours. So that will be enough to help the patient hydrate. And okay, so after the session, you will be much more clear about that. So, and also next, the patient has to be assured proper analgesia. And sometimes when the patient is more evolved and all these symptoms will be refractory, that they won't be responding to the normal our treatment techniques. And that's a condition we may have to go for palliative sedation. So coming to the drugs used, the anticholinergics or anti-secretory drugs, they are used to reduce the distension and the colicky and spasmodic pain. So one drug is most commonly used is hyoscine butyl bromide. It can be given as 10 milligrams 6 hourly or continuous subcutaneous infusion, maximally to 120 milligram over 24 hours. So some centers are very with transdermal patches of hyoscine butyl bromide. Then hyoscine hydrobromide is there. Glycopyrrolate is very commonly available in most centers. So you can even go for 0.1 to 0.4 microgram per day. Octreotide injection is a continuous infusion. It's also useful for intestinal obstruction. But studies say that there is much no like beneficial over other drugs with octreotide. Some studies say that, and octreotide is obviously costly. Injection nantrin as infusion, 150 to 200 milligram per day, to reduce the upper GI secretion and distension. So this is why I suggested 100 an hour PPA, proton pump inhibitors. So anti-inflammatory, the steroids. Dexamethasone is the drug we use commonly because it's a long-acting one and a single-day dosage could be used. It can be given as a slow IV or a 6 milligram subcutaneous route also. Once the patient's nausea and vomiting has come down, we can even opt for oral routes in incomplete bowel obstruction. So when do you stop? If you couldn't find any clinical improvement in like 5 days or the side effects appear, and you find that it's not going to improve the quality of life of the patient, you can stop the dexamethasone in 5 days. Once if it goes otherwise and the symptoms are relieved, we can gradually wean over a period of 2 weeks. You can reduce the dose and stop over 2 weeks. The prokinetic antiemetics, always watch for colicky pain. If the colicky pain is presenting, do not give prokinetics, you have to stop. Okay. So you can give oral or injection metoclopramide 10 milligram, 4 to 8 hourly, maximally up to 30 milligram, 30 to 40 milligrams. Thing is that domperidone is mouth dissolving and rectal suppositories are also available for domperidone. Antiemetics without prokinetic action, when there is a colicky pain or the patient is very severe, we can go for haloperidol. Haloperidol can also help with the process sedation. So sometimes the patient may ask for some sleep, and haloperidol would be helpful. It is usually used as a second line antiemetic. So you can go for a 0.5 lower dose rather than the dose that you give for delirium or as an antipsychotic. 0.5 or 0.75 milligram once daily to start with, and slowly you can titrate up maximally to 5 milligram. Ondansetron can also be used, but one thing is ondansetron may precipitate constipation. So you have to make sure enough laxatives are also being added. So the major thing, what about the supportive care? We have to make the patient and the family prepared for what they are going to face. You have to demonstrate and educate on mouth care using lukewarm water with salt and soda bicarb. This will help with the patient's thirst, oral symptoms, and nausea to some extent. Involve the family in the care of the patient so they will get much time together. Communicate, have a good communication with the family and the patient. Check for the insight, communicate with the patient and family regarding the prognosis. So bowel obstruction is something that is indicative of a poor prognosis and indicating that the end of life is also near. So we have to communicate the patient and family members. Ask for any advanced care planning or what they want to do, whether they want to go for surgery or is there some wishes they have to get done. Okay. Always informed, supported, shared decision making and documentation. Always make sure you are documenting well. All the decisions are well documented. Palliative surgery can be beneficial for someone. So if you feel that, if the surgeon or you yourself feel that surgery could improve the quality of life of the patient, and the patient is a good candidate for surgery, yes, we can go for surgery. Then other things like preferred place of care, where the patient wants to be. As a patient, is the patient okay to be continuous care with the hospital setup, or does he want to be at home? About parenteral hydration, they will be asking for IV fluids because the patient is not taking anything, severe vomiting. So you'll have to let them know of the benefits and risk. See, continuous hour hydration will definitely increase the intestinal secretions, which will add on to the patient's distress. So we'll have to inform them of the benefit and the risk of hydrations. About the nutrition, they'll be keeping on asking, he's not taking anything, he's in severe hunger. What should we do? So we have to tell them. Provide emotional support to the patient and the family. Prepare for them for an end-of-life event. Give them symptom relief, emotional, even legal support required, preparation for the patient and the family, met with their unfinished business, religious and spiritual care. So thank you. That ends the session. We are open for any doubts. If you have any doubts, you can ask them.
Thank you, Dr. Arjun, for the presentation. Anybody have any doubts regarding this presentation? Please ask him. Sister Kanchan,
Yes,
do
ma'am.
you have any doubts?
No.
No. So one chat question: well, which side is appropriate for subcutaneous fluid?
Right. Okay. So we generally use 4 sites for subcutaneous drug administration or fluid administration. Midway between your so midway between upper arm, both sides, and you can go for anterolateral side of the thigh. and chest region is also a suggestion below the scapula level, but it's very rarely used because it's somewhat kind of painful also. You will have a session on subcutaneous fluid infusion, subcutaneous drug administration on coming sessions.
Any other questions? I hope that presentation is clear. So before we move on to the case presentation, I would like to highlight few things. So here we have learned many things on intestinal obstructions. So when a patient comes to you with symptoms nausea, severe nausea, vomiting, and abdominal pain, you have to evaluate, you have to assess properly. So there are two different types of obstructions. One is complete obstructions, and the second one is incomplete obstruction. So if the patient is having partial obstructions, you can ask doctor said you can give dexamethasone steroids that will help to reduce the peritumor edema. Along with that, you can give prokinetic like metoclopramide that will help to stimulate the bowel contents. So the important thing you have to observe the patient is once you administer metoclopramide to the patients, you have to that closely monitoring to the patients, because if the patient has developed colicky pain after you starting metoclopramide, there is a chance of complete obstruction. So you have to report to the doctor immediately. Then you can you have to stop the infusion also. So in case of complete obstruction, sir said, you have to give anti-secretory agents like buscopan. So that will help to reduce reduce the intestinal secretions, and also you can give some analgesics and control their pain. So if there is a lot of secretions and intestinal contents there, you can insert a nasogastric tube and you can aspirate the secretions, intestinal secretions. So that is the management of intestinal obstructions, complete obstructions and the partial obstructions. And another important thing you have to keep it in your mind is don't mix prokinetic and the buscopan together. So prokinetic means metoclopramide. Metoclopramide is the prokinetic that will help to stimulate the bowel motility, but the antispasmodic is buscopan. So that will reduce the bowel motility. So don't combine together. And also the spurious diarrhea. That is also very, very important when after a period of constipation, when a patient comes to you with the complaining of diarrhea, you have to do take a proper history and bowel movements and all. So then you can do the PRE, per rectal examination, and find out if there is a bowel fecal matter, the fecal matter is obstructed in the higher part of the bowel. So that when you do the PRE, that time you have to, that there is a balloony feeling will be there. You can't, you are not able to touch the rectal mucosa. Usually when you do the PRE, we can able to touch the rectal mucosa if there is a that fecal obstructions there, you are not able to touch the fecal mucosa, that rectal mucosa, that is the balloony filling. So then you can do one thing, you can insert a suction catheter through the anus as much as possible. You have to introduce, and then you can give 2 high phosphate enema at a time. So that way we can able to relieve that spurious diarrhea. Okay, so that will that sodium phosphate enema go up and help to contract, stimulate the bowel contents. Okay, so we can move on to the case presentation. Kanchan Kumari will be presenting a patient story today. So Kanchan, welcome and over to you.
Good afternoon, everyone. My name is Kanchan Kumari. I was staff nurse, Harbatpur Christian Hospital in Dehradun. Today's present my case presentation. Present detail: 32 years male, female, diagnosis of cholelithiasis, presenting complaining abdominal pain and vomiting. History of illness: no surgery history of hospitalization, no surgery history, no history of any chronic disease. Examination are physical examination, vital signs, BP 120/70, temperature 99 Fahrenheit, pulse 96, respiration 24, weight 60 kg, height 147. Neurological examination oriented cardiovascular system dizziness, respiratory system dry cough, GI system nausea and vomiting, abdominal distance tenderness, bowel sound absent, urinary system catheterization, skin normal, knees normal, hair are normal, nose normal, muscular system are normal, joint no pain, endocrine system thyroid normal. Surgical investigation, surgical diagnosis investigation, ultrasonography, routine CBC, WBC 56, platelets 1.46, HB 13.3, total bilirubin 0.30, direct bilirubin 0.11, 3 are H negative, blood group B positive. Treatment are preoperative medical treatment, NG tube inserted, NPO, in fluid are DNS, NS, catheterization, surgical treatment, laparoscopy, gallbladder removed from a small opening. Physiological aspect, anxiety, fear of surgery. Medication are antibiotic injection, amoxicillin 1.2 gram, antiemetic injection, Pentof 40 mg, antiemetic injection, Perinom 10 mg, anti-hypertensive injection, PCM 1 gram, analgesic Vovron 75 mg. Main concern: her fear and anxiety will be reduced after brief explanation about her surgery. Her will be able to perform her daily activity. Summary are: prognosis was good. Her condition was improved by getting medicine, surgical and nursing care, health education, diet, medication, follow-up. Discussion point: pain management, patient relationship with staff. Thank you.
Thank you, Kanchan, for the presentation. Anybody wants to clarify regarding this? Any more clarification needed? Please ask her. Otherwise, we can move on to the discussion points.
Kanchan, can you go up to the medication part once more?
Yes, sir.
So I hope no need of clarification is needed for this presentation. Nobody is need any more clarification. The presentation is clear. So from this patient story, you can understand that this patient is also developed nausea and vomiting. So what you have learned from this patient story? We have learned intestinal obstruction today. From this patient story, what you have learned? Any specific points? Please unmute yourself and talk.
Patient problem has been corrected after surgery.
Okay, ma'am. Thank you, Masima, ma'am. After surgery, we can able to manage. We can able to manage these symptoms. Okay. Any other points? Vowel sounds. Okay, Meenakshi said vowel sounds. That is very good assessment. So you have to, whenever the patient complains any gastrointestinal kind with any gastrointestinal problems, you can check their vowel sounds. Okay, then
Minimal surgery has been performed. It's like laparoscopy. So they have not done the open laparotomy, but they have done the laparoscopy. So patient can recover very easily also.
okay. Thank you. Any other points? Allow me.
I think the symptoms before the operation, they used NG tubes for it, and also they had her NPO, and then they performed the surgery. So they helped her to cope with the symptoms before the operation.
Okay, thank you. So as you all said, this patient is complained that before he has a lot of problems, nausea, vomiting, and other physical problems. So after the surgery, he has relieved his symptoms. So from this patient story, we have to understand that not all that patients with nausea, vomiting, continuous vomiting or pain. It's not always intestinal obstructions. So, it could be other diseases too. So you have to take a proper history and proper investigation and find out the diagnosis, and if curative possibility there, you have to refer the patient to the appropriate session. So here, this patient need a curative management, and he has relieved his symptoms. So this patient is also need palliative care along with the curative treatment. Definitely, he needs palliative care. You can give a supportive care if along that from during the curative treatment, if he develops any signs and symptoms, you can try to control his symptoms. So that way we can able to improve the quality of life. So also he has some anxiety about his that problem, the disease. So at least you can listen their problems. Then that way we can able to reduce his anxiety. So you can give a proper explanation. So then he can understand well, and that way we can able to reduce his that anxiety level, and also you can give psychological support to the patient, not only for the patient, it's for the family too. So always you can listen their families worries too. So if they have any doubts or any clarification needs, you can try to clarify their doubts. Okay.
Okay, so do you think this pain medication would have been benefit enough for the patient? So the patient received paracetamol and Movaran for the post-surgical. So was the patient having good pain relief after this? Arjun?
Kanchan, that patient got adequate pain relief with Movaran and injection paracetamol?
Yes, ma'am.
Yes.
Okay, very good. Okay, so this is a reason why we should be having a good pain relief. So we have to ask. So once you know that how to manage, assess the pain and the necessary medications for that, once you can give the patient a good post-operative pain relief. Okay, so how is the patient now?
Sorry, sir.
How is the patient now?
The patient is good and that discharged.
Okay, good. Thank you.
Anybody wants to add any points? So if you don't have any questions, we can wind up the session. So today we have learned many things, especially intestinal obstruction. So I think this is a new information for you all about intestinal obstruction. So as I mentioned earlier, always try to, when a patient comes to you with abdominal pain and nausea, vomiting, you have to do the proper assessment, and if possible, if the patient is health status is so good, you can refer the patient to the surgeon and see whether there is any surgery is possible or not. So if there is a complete obstruction, for example, if there is a complete obstruction, but the patient health status is okay, no metastasis there, then you can refer the patient to the oncologist surgeon and ask them is there any chance to do the colostomy. If that way we can able to manage. If there is a colostomy possibility there, you can do the colostomy. That kind of thing, or the thinking always there when you see this type of patients. And also try to listen the patient's family stories too, so that patient this kind of situation that patients will be anxious. So what is next? What is next? That question is always inside their mind. So always try to listen their worries, and as much as possible, you can try to solve the problems. If you are not able to solve the problems, you can connect with the social workers and elicit their problems. So that way, we learned in the first session onwards, we need a good teamwork for improving quality of life. So as much as possible, you can try to connect with other people. Our that vision is to improve quality of life and to relieve pain and other symptoms. Once you try to relieve the symptoms, so definitely their quality of life will be improving. So always try to listen their worries and listen their problems, and to try to relieve their problems. And also from today's sessions, you understand that there are two different types of obstructions: complete obstructions and partial obstructions. So that management is also different. So always keep it in mind when a patient. So we are nurses to carry out the medications, and also you have to try to observe their problems also. So after you that carry out the medications, if they develop such symptoms, any that symptoms worse, so you have to report the physician as soon as possible. Then you can stop the infusions and then go for the next management. Okay, always try to communicate each and every situation to the family and the patient as much as possible. Okay. So, and also you have to prepare the patient. If there is a complete obstructions, there is no curative possibility or no further management is possible. You have to prepare the patient and the family members for that. For maybe one tech will be near them. So we have to listen their worries, and every day you have to communicate with the family members. So otherwise they will, if suddenly death happen, so they will ask you why you didn't tell us is this much of problems here. So always try to communicate each and every situation. Whenever you see that patients, after they, when you come out, you have to talk to the relatives about the current situations. How will you, how are you, how you manage that symptoms and all. So you have to ask them, is there any other options they have also that you can think about. So sometimes this kind of patients can develop dehydration too. So that way, that time they are not able to take fluids through orally. Then you can that time you can manage with the subcutaneous infusion. So we have a session on subcutaneous infusion later. So next week, I think. So that time you will learn more about that. Okay, thank you once again. Thank you, Dr. Arjun, for the wonderful presentation. Thank you, Kanchan, for the patient story. Thank you. See you next week.